Hi, this is Dr. Poole, and this presentation is going to be somewhat of a review of normal liver histology, but in relationship to pathology and major patterns of hepatocellular injury. As you've probably learned from your anatomy labs, the liver is a large organ weighing normally about 1.4 to 1.6 kilograms and comprises about 2.5% of normal body weight. Similar to the lungs, it has a dual blood supply. About 70% of the blood volume comes from the portal vein system and about 30% from the hepatic artery. Now, functionally, the liver is a very important organ because it's the center of metabolic activity for processing all dietary nutrients, also storage of minerals, and it's an important site of protein synthesis as well as detoxifying harmful products, both metabolic products as well as drugs and other toxins. We can look at the microarchitecture of the liver a couple different ways. The classical model is the liver lobule. And in this model, a lobule, which is outlined in blue with the hexagon, is drained by a central hepatic vein, which is labeled H. Now, P at each of the corners represents a portal triad, and the portal triad we'll look at in a little bit more detail on the next section. Now, the arrows pointing back and forth indicate the directional flow of blood, indicated by the red arrows, which blood flows from the hepatic artery branch that's in the portal area towards the central vein through sinusoids. And then the green represents bile, which is manufactured and flows in the opposite direction from the central part of the lobule to the bile ducts that are located in the portal triads. This is a high-power view of a portal triad, and the three essential elements are the portal vein, the bile duct, and the hepatic artery. Now let's look at that in a little more detail schematically. So the upper left-hand figure, figure A, shows a hepatic lobule. This is in a more three-dimensional view compared to the two-dimensional microscopic slide, but you can still kind of make out the hexagonal arrangement. Kind of a cutout of that in figure B shows a three-dimensional representation of one of these hepatic, a portion of the hepatic lobule. And you'll notice that the red vessels are branches of the hepatic artery located in the portal triad, and you can see that blood is flowing through the sinusoids, and that's represented by the red and blue vessels towards the central vein. Now you'll note that each cord or column of cells, which are represented by the tan cells, those are the hepatocytes, and it's of note that each cord of cells is separated by the hepatic sinusoids, and they're one cell layer thick, and that changes in pathology. In the diagram, they label Kupffer cells, which are modified macrophages and lie along the sinusoids. And then the other component is these biocanuliculi, which are actually located between the individual hepatocytes, and then these flow into into larger and larger bile ducts until they reach the branch of the bile duct at the portal triad. The panel on the left, high magnification of the liver to illustrate the arrangement of the cords between the sinusoids, and I'm pointing out here the sinusoids, the K. This is a special stain to highlight the Kupffer cells, which also highlights the sinusoids. And the panel on the right, panel B, is a super high magnification of adjacent hepatocytes around a sinusoid. So the sinusoidal space is labeled S, and this is the area between this row of hepatocytes on this side and this row of hepatocytes on this side. Now there's a couple specialized cells that I want to point out in this area. So the sinusoids themselves are endothelial-lined blood spaces that contain an admixture of portal venous blood and hepatic arterial blood. And the E cell here is one of these endothelial cells. Now these endothelial cells have gaps between them called fenestrations, and this allows for easier passage of material into this space. Now beneath the endothelial cells is the so-called space of Dissa, or perisinusoidal space, labeled PS. So this is between the hepatocyte and the endothelial cell. And if you looked at that space under electron microscopy, this is where numerous microvilli of the hepatocytes reside. There's another specialized cell that's located in the sinusoid, and these are lipid-containing myofibroblastic cells called hepatic stellate cells, and this is labeled HS in this diagram. And these numerous clear droplets are the lipid that's contained within these cells. Now these cells are important because under pathologic conditions they produce fibrosis, and we'll talk about that a little bit later on in another presentation with this case. Between abutting hepatocytes are biocanuliculi, and these are 1 to 2 millimeter channels that are formed by grooves in the plasma membranes between opposed hepatocytes. These drain into bile ductules in the periportal region, which in turn empty into terminal bile ducts in the portal tracts. And then finally, the cells identified as K are the Kupffer cells. And these are specialized macrophages that are attached to the luminal aspect of endothelial cells. These cells are important in inflammatory reactions, as well as they're involved in fibrosis. And this is a drawing just kind of summarizing what I just went through. Again, showing the hepatocyte ultrastructure and their major functions. And kind of the point of this is to emphasize the structure-function relationships, which are especially evident in the liver. Now there is another model of liver microarchitecture called the hepatic acinus. And in this model, the structure is understood based on the delivery of oxygenated blood. So in acinar zone 1, the P are the portal areas which contain the hepatic artery, and so the most oxygenated blood will be in this zone, zone 1. Zone 2 is an intermediate area as we move from the portal tracts to the central vein, and then acinar zone 3 is where the least oxygenated blood is, because now it contains more of an admixture of portal venous blood, and as you might expect, this is the area that would be most susceptible to ischemia, or conditions which place an unusual load or stress on hepatocytes. So I included this slide as a summary of the structure-function relationships with the liver histology. On the left, A, we have the classic hepatic lobule, with blood flowing past hepatocytes from the portal areas to a central venule. And this emphasizes the endocrine function of the structure, producing factors for uptake by plasma. The concept of portal lobules of hepatocytes is more useful when considering the exocrine function of these cells, that is, bile secretion. The portal area has the bile ductule at the center, and bile moving in the opposite direction as the blood flows towards it from the surrounding hepatocytes. The tissue draining bile into each portal duct is roughly triangular in shape, with the central veins of 3 classic lobules forming its angles. So this triangle here. And finally, the hepatic acinus is a third way of viewing liver cells, which emphasizes the nature of the blood supply to the hepatocytes and the oxygen gradient from the hepatic artery branch to the central vein. In a liver acinus, hepatocytes make up an irregular oval or diamond-shaped area that extends from 2 portal triads to the 2 closest central veins. So here's the diamond shape. I just showed half of it in the microscopic image, but you can conceive it as this diamond shape, including 2 portal areas and 2 central veins. So periportal hepatocytes nearest the hepatic arteriole, comprising zone 1 in the acinus, get the most oxygen and nutrients and can readily carry out functions requiring oxidative metabolism such as protein synthesis. Hepatocytes in zone 3 near the central vein get the least oxygen and nutrients. Thus, the hepatocytes in this zone are the preferential sites of glycolysis, lipid formation, and drug biotransformations, and are the first hepatocytes to undergo fatty accumulation and ischemic necrosis. In the intervening zone 2, hepatocytes have a range of metabolic functions between zones 1 and 3. The major activities in any given hepatocyte result from the cell adapting to its microenvironment, produced by the contents of the blood to which it's exposed. So with that background, we can now talk about some of the major patterns of hepatocellular injury that we'll study in more detail with regard to specific disease entities. So the major patterns are necrosis, inflammation, which can be localized to portal or lobular areas, a phenomenon called ductular reaction, steatosis, which is the accumulation of lipid, pigments and other intracytoplasmic accumulations, and then finally fibrosis and cirrhosis. So let's talk about these in a little bit more detail. So necrosis occurs in 2 patterns. Both of these you've heard about in other contexts. One is apoptosis, which is individual cell necrosis, and this takes a programmatic form of development. That is, it's a planned sequence of events. The morphologic appearance in the liver of apoptotic cells are called acidophil bodies, as I'll show in the next slide. And in this situation, the hepatocytes shrink and eventually fragment to produce these eosinophilic apoptotic bodies. Now, the other type of necrosis is hepatocyte necrosis, which can either be focal, and usually this is marked by the accumulation of macrophages where the cell disappeared, or it can be confluent, involving larger areas of hepatocyte necrosis, and you see loss of hepatocytes in zones. Kind of a twist on this is that the necrosis can be so-called bridging, and you'll see bands of necrosis extending from portal veins to central veins, or from adjacent portal areas to each other. So just be familiar with these terms of focal necrosis, confluent necrosis, and acidophil bodies, which also has a couple other names. So an apoptotic body, aka acidophil body, also known as Councilman body, specifically in yellow fever, is this shrunken eosinophilic cell which you can see by its stellate shape is kind of retracting from its neighbors, and the nucleus is very condensed and dark, which is called pycnotic. This form of necrosis predominates in viral autoimmune hepatitis as well as in drug and toxin-induced injury. So for right now, I'm going to skip over talking about hepatocyte necrosis because that'll be a big portion of the presentation with regard to liver failure. So I'll move on to patterns of inflammation. Now for right now, just be aware that you can have two different localizations of inflammation. One is called portal inflammation, in which the inflammatory infiltrate is centered on the portal triads, or lobular inflammation, which is where the inflammation is in the hepatic lobules. Nothing too tricky there. Now, we'll talk a lot more about this in the next case as opposed to the current case. So I'm not going to go into too much more detail about this. And in reality, oftentimes you see inflammation in both microanatomic compartments. Another pattern of hepatocellular injury is called ductular reaction. And this is the proliferation of these bile ductules at the interface of portal tracts and liver tissue. So I'm pointing out and circling the proliferation of these small little ductules and ducts. This is a nonspecific pattern, so it doesn't point to a specific disease. It can develop as a result of any kind of bile duct injury or hepatocellular injury. And it's not used to be called bile duct proliferation, but it's so much more than that. It's associated with a variety of stromal, vascular, and inflammatory changes that you don't really readily see on the microscopic slide, but it manifests as this proliferation of bile ducts. So it's kind of analogous to pathologists. There's so much more than meets the eye. Another pattern of injury is steatosis, and this is the accumulation of lipid in the cytoplasm. This can take two forms, either called macrovesicular or large droplet, in which there's a single intracytoplasmic vacuole that enlarges the cell and compresses the nucleus to the periphery of the cell, or microvesicular or small droplet, in which there's multiple small fat droplets in the cytoplasm that do not displace the nucleus. Now this particular image shows a mixture of large and small droplet steatosis. The pattern and type of steatosis is important to note in conjunction with other histological findings that provide clues to specific types of liver injury. So we use this pattern of steatosis in context with other histological clues to make a diagnosis. When steatosis occurs with inflammation, we call it steatohepatitis, and when it occurs with fibrosis, we call that steatofibrosis. So this is just a high magnification view of these two different types. In macrovesicular steatosis, you have a large single droplet of lipid that displaces the nucleus to the far periphery of the cell. Whereas in microvesicular steatosis, we have these multiple small droplets, and the nucleus is actually still centrally located. Now the other major patterns of liver injury will be discussed in more detail in upcoming cases, particularly talk a lot more about fibrosis and cirrhosis in the content with this case in the next presentation. So let me summarize what I learned in this. There are organizing principles to the liver that relate the microarchitecture to functional relationships. The one principle is the lobule, and the other concept is the acinus. And then you learned about major patterns of hepatocellular injury that you'll take moving forward when there's learning about more specific disease entities. And that's Necrosis, which can either be individual cells, what we call apoptosis, or confluent. Different inflammatory patterns, which can be centered on the portal triad, or which can be distributed throughout the lobule. Steatosis, the accumulation of lipid, which can either occur in large droplet or macro steatosis, or small droplet microsteatosis forms. There's a variety of intracytoplasmic accumulations that we'll talk about in more detail in upcoming cases, so don't worry about that for now. And then fibrosis and cirrhosis, again, I'll talk about that in more detail in the next chalk talk. And part of that is the phenomenon called ductular reactions. So that's my summary to kind of get you grounded moving forward. Thanks.